Welcome to this activity on OAB, discussing guidelines, diagnosis, and therapies. I'm Dr. Matt Rosenberg, Medical Director of Mid-Michigan Health Centers in Jackson, Michigan. I'm joined today by Elizabeth Zwick, who's a PA also at Mid-Michigan Health Centers, and Quentin Clemens from the University of Michigan. This program consists of 3 video segments. During the video segments, key points of emphasis along with relevant resources will appear at the bottom of the screen. You may be asked to answer questions on the right side of your screen, and you can take notes by clicking on the Add Note button. These notes will be emailed to you after participation. A resource library can be found by clicking on the magnifying glass icon. And now let's get started with the first topic. All right, Liz, I'm going to start with you. Let's start with a theoretical case. We have a 54-year-old woman who comes into the office. She has urinary urgency that's interfering with her job. She doesn't report of any incontinence, just a sense of urgency, and she's actually had some close calls where she feels like she would wet herself, and that's what brought her into the office. What would you do?
So we're in a primary care setting. We often know quite a bit about these patients ahead of time, but we're of course going to conduct a thorough history. We would start with questions about past medical history. We'll talk about their surgical history, and we'll also talk about social history as well.
Okay. Let me stop you there. Let's talk about when the patient comes in, what about the acute nature versus the chronic nature of these symptoms?
That's important to talk about, because if this was something that came on suddenly, we're thinking more along the lines of of a urinary tract infection possibly. If this is something that's been going on for a while, then we're thinking more OAB.
What's a while?
Maybe months or years even. Sometimes people wait before they come in and talk about these symptoms.
It's something that maybe prompts them to come in.
Right.
Okay, so you've developed the symptoms. Let's just say, for sake of argument, that she's had the symptoms for a while. Let's say 6 months, okay? And actually, let's say she may have even had it for years. It's just getting worse, and over the 6 months, she's noticed that as to be worse. She talks about urgency. She talks about, maybe she mentions frequency. She's not losing urine. What about the timing of this? Is it, do you want to know, is it a sort of a temporal relationship during the day or day and night?
Right. So you want to know if this is happening at night, if this is an all-day issue, or is this something that's happening at different times? Perhaps it's more of a behavioral issue.
Right. Right, because the patient who comes in and says, I'm only having this problem at work for the first 4 hours of the day, and then you find out they're drinking 2 pots of coffee right before they go to work, which, you know, certainly could happen. What things in their medical history might you be interested in?
Certainly want to know if there are some diagnoses like hypertension for which they'd be taking medication that could cause some of these symptoms. You'd want to know if they're diabetic, or maybe they haven't been diagnosed as diabetic yet, so maybe they're drinking a lot of water or other liquids. And you certainly want to know about their past history as far as surgeries and things go as well.
Give me a couple examples on surgical things that you might have seen in the clinic.
You know, if they've ever had any surgery in the pelvis, that would be important to know whether or not there's going to be some scar tissue going on. So.
Okay. And you and I shared a case not long ago. We had a patient come in who had just had hip surgery about 2 months before, and she was complaining of urinary urgency and frequency. What did we find with that?
That she was, you know, having a hard time getting to the bathroom. So perhaps she was waiting a while because she's in pain and she's still recovering. You know, again, getting to the bathroom, maybe ignoring those first signals that it's time to go, and got herself into trouble waiting too long.
Right, and what was interesting with her was that these symptoms had been going on for a while, but it was something that kind of tipped her over the edge, and this was the fact that now her ambulation became a problem. Right. And the other point, if you recall, was when we looked at her meds, which is probably our segue here, what medication was she taking a lot of?
Norco, so pain medication, so she probably hadn't had a bowel movement in a few days, and that's going to create some issues as well. Yeah, because of that added pressure.
What about other medications that you might think about?
Certainly diuretics are medications that you'd want to think about. For our diabetics, where they recently started on like an SGLT2, that would cause more urination.
Right. Absolutely. And we have found certainly sometimes in the office where the patients will be coming in and it's the timing of their diuretic when they're taking it, or maybe they had upped the dose, or maybe they just started a dose and they didn't realize that when their cardiologist put them on this, if that was who did it, that it may be affecting some of their urinary habits. Right. What about social history? Is that important?
Absolutely. So in this case, this patient is a teacher, so she probably has a hard time getting to the bathroom on demand. You know, she can't just leave her classroom. So again, she's probably more bothered by these symptoms than someone who has the ability to access the bathroom whenever they need to.
Right. And one of the things we find is that because they have to rush out, because God only knows what the kids are going to do to the classroom while they're gone, they'll void to the point of comfort, but not necessarily to the point of completion. So I think that's covered it for the first part of the history. What about the physical exam? So she comes in. Now, granted, she's been in the office, and we probably did her physical sometime within the last 12 months, but what type of things are we looking for?
You certainly want to check the abdomen, look for any sign of scars. You'll want to palpate and also make sure that there's no masses or any sign that they're, have a distended bladder.
Right. Well, tell me about that. We had a patient, we've had a lot of interesting patients. We had a patient come in who new onset, young girl, she was in her 20s, I believe.
Right.
She came in with new onset of urinary symptoms. What did you find on the abdominal exam?
That she had a large mass in her pelvis. It was an ovarian tumor, I think is what it turned out to be.
And that was causing that pressure. And she'd been having this for a while, but this tumor had been growing for a while and she hadn't brought it to anybody's attention. What about the genital urinary exam? What are you looking for?
You're going to, especially in a woman 54 years old, which is probably postmenopausal, you're looking for any atrophic changes. You're looking for signs of prolapse that could be obstructing the flow of urine. You definitely want to do a rectal exam and check tone to kind of help assess whether there's a neurological component.
Sure. Sure, and let's talk about the neurologic exam. Neurologic issues can cause some urinary things, so what are you going to look for?
Typically, you'll watch them walk into the room, as their gait, abnormal. So a lot of it you can glean from just your interaction with the patient.
Perfect answer. Okay. What about labs? What do you want?
So we certainly conduct a urinalysis in our office. You want to look for any sign of infection. Any microscopic blood, hematuria is going to be more complicated and definitely something you're going to want to refer or continue that workup for. You'll also, in some patients, you'll be able to detect whether there's glucose in the urine if it's high enough, their blood sugar. But if, for instance, they've come to our office and they're fasting because it's their physical, you may not pick that up because the glucose has to be over 180 in order for it to spill into the urine.
Right.
So in our office, we're always screening for diabetes, whether we're doing a blood sugar randomly or fasting or getting an A1C.
Okay. Great. And then any additional labs you want? I think we've covered everything. How do you feel about voiding diaries?
We love them. Bladder diaries are great. So it's helpful to assess, again, what kind of volumes are we talking here, get ideas about their behavior. It's great for the patient to do that at home and get a better understanding of where they're starting so that as we're treating, they can see what kind of progress that they've made.
Right.
And
it's also helpful to use that diary to go back to the initial symptoms, because if we're thinking about overactive bladder, it's a bladder that's not doing what it's supposed to do.
Right.
And normally the bladder will hold 300 to 500 mLs and should comfortably empty 300 to 500 mLs. Overactive bladder, by definition, is when the bladder can't hold that. So you're voiding at 50 or 100 or 150. So we're going to see frequency of small volumes. Right. And where that diary is going to help us is if they're coming in frequently of small volumes, I'm thinking OAB. Right. On the other hand, if it's frequent of large volumes, now that's really more of a medical condition.
Correct.
Yeah. So let's actually, that was perfect. Thank you so much. Quentin, you're up now. So you've recently authored the AUA SUFU guidelines, which, great job. I had a chance to read that a couple of times. Can you take us through those recommendations for making a diagnosis of overactive bladder or OAB?
Sure. Well, so the OAB guidelines indicate really evaluation that Liz outlined, starting with the history, physical exam, and urinalysis. And the history focusing on the details of the symptoms, of course, and duration and severity, but also it's important to talk about things like goals of therapy. What is the primary symptom or symptoms that are bothering the patient, and kind of focusing in that direction. And then often looking for modifiable factors such as caffeine consumption or bladder habits. Are they urinating very infrequently throughout the day for one reason or the other? And those might be some easy targets for modifiable therapy. On physical exam, looking for pelvic mass. I certainly recommend a pelvic exam for each patient, and also some assessment of how well the bladder is emptying. And then the urinalysis, predominantly they're looking for blood, but also if there's obvious evidence of infection, and certainly if the symptoms came on recently, then there may be a suggestion that this is just a bladder infection, and treatment with, culture and treatment with antibiotics would be indicated. There are some additional tests then that are suggested as possible. A bladder diary is one. That can provide a lot of useful information about the nature of the symptoms, but also we find that it can actually help the patient's symptoms get better by completing the diaries and kind of providing them with some insight about triggers, etc. So it can be very therapeutic. And then a post-void residual assessment, which for us urologists is very easily available. And so in my practice, virtually every patient who presents with OAB will have that done. Cutoff there is about 200. So if it's above 200 is where we start getting concerned about bladder emptying. And then finally, there's some...
Can I stop you just for a second? Because in my world, most primary care don't have a post-void residual assessment tool available to them. And they're not going to catheterize somebody because unfortunately that's tremendously uncomfortable and patients won't come back. So I had this patient that Liz had mentioned. We had the symptoms. In this case, it's a female. We'll talk about a male at another point. So we're not worried about obstruction. She didn't find anything on the exam. I'm going to push you here. Does that family doctor or internist need to do a post-void residual, or can we do empiric therapy?
Sure. So I think the answer is they do not need to do a post-void residual. I would suggest that they check and have some assessment with a physical exam, make sure that the bladder is not massively distended. Again, the post-void residual was, in the guidelines listed as an optional test, and I would say my practice is certainly very different from a primary care practice where I see a lot of patients who have failed initial therapies, etc. So it is not necessary, and in fact, whereas we used to be quite concerned that, for instance, starting bladder OAB meds would cause urinary retention, we now know that that risk is extremely low, and they can be given safely even in patients who have a moderately elevated PVR that you might not pick up on exam.
Sure. So if your physical exam on this school teacher is normal, you're not seeing a prolapse, there's no masses noted on either the vaginal exam or the abdominal exam, you're going to be okay. We don't need a post-void residual. But if, when we do talk about treatment, which we'll do later, we could say something like, we're giving you this medication. If we give a medication, it may slow your bladder down, which is the goal of this. If you haven't been able to void in whatever period of time, 6 hours, you need to let me know.
Yeah,
but
absolutely.
That's a safety mechanism, and we've done that for years in the office, and I can't remember putting anybody into retention.
Right.
So,
yeah,
great.
So the final point I'd make is there are some tests that are listed as really not tests that should be done routinely, which includes cystoscopy, urodynamics, and urine cultures on every patient. And so really those are more left for more complicated patients who need farther workup.
Sure. Quentin, that was a great review of the guidelines, and I really appreciate that. And it's really nice to know that most of what we can do in a primary care setting is we're doing, following the guidelines. And and as you'll hear from me a couple of times, I really believe that the preliminary or the initial evaluation of most of these patients can happen in the primary care setting, and so can the treatment. But what we are concerned about in primary care is the fact that we don't want to miss anything. What can be happening that maybe we think is OAB, but it's something else? So what are those red flags that we should be worried about for when we should be sending off to the specialist?
Sure. Well, I think one is any concern about malignancy, and in particular hematuria, whether it's gross or microscopic hematuria, should prompt a referral. Evidence of a pelvic mass on exam. Otherwise, more complicated situations such as a patient who has significant pelvic prolapse or a significant neurologic disorder. Someone who's had prior surgery or radiation for a pelvic malignancy, someone who's had a prior pelvic surgery for incontinence or prolapse, especially recent surgery like that. And then I also think, certainly someone who has already tried a number of treatments and failed. And then finally, someone who has really very severe symptoms, not necessarily like the patient we're talking about now, but some patients present with very severe incontinence. And yes, they might be fine to start them on a bladder med, but most likely they're going to require additional diagnostic tests and or treatments. And so that might be an indication for referral perhaps after starting the med and maybe briefly assess assessing if they've responded somewhat to it.
And you brought up incontinence. I think that's a great thing. So if not that incontinence is a great thing, it's a great thing you brought it up, but if a patient is having incontinent episodes after an urge, that's really the classic OAB. But one of the things I will try to understand from the patient is, are you leaking urine without an urge? Because that's more of the stress incontinence, and there's really nothing available to us in primary care short of a pessary that's going to be helping that. So that would definitely be a good referral for us. And I appreciate the fact that you said, you know, that we just need to be communicating on this in the sense that we can start something up, but knowing that they may need some other help, we can initiate that referral pattern. And then on if prior to that appointment, whatever we've initiated has worked, then we can probably postpone it. That's fine. Let's talk about the impact. Very briefly, Liz, what is the impact of this? What do you worry about?
This is definitely a quality of life issue, and this teacher is a great example of someone whose work life might be affected by this condition. So the fear that she's getting close to having incontinence, this urge that she suddenly can't ignore and she needs to leave the room, is difficult in a number of different fields. We also worry about the patient who maybe doesn't have great mobility, trying to rush to the bathroom in the middle of the night. Maybe they're putting themselves at risk for a fall.
That's no longer a quality of life issue, though, is it?
No, that's a safety issue.
That's a safety issue. I mean, we talk about, for example, osteoporosis. We treat that very aggressively. A lot of advertisements on making it so that if you fall, you bounce, you don't break. So we give a lot of medications, but maybe we should be looking at the reason why people fall. And in the middle of the night, the chances are you're getting up to go to the bathroom. So if we can handle that bathroom issue, we could be saving a lot of people. And the morbidity or the mortality associated with a fall, I think it's 80% in men in the first year and about 50% in women. So it's very significant. So it's more than just a quality of life issue.
And back to quality of life, you know, the patient who's worried about where the bathrooms are all over town may be abstaining from going to different events, might be missing out because they're afraid that they might be in a situation where they can't get to a bathroom in time. So
and especially in an elderly patient who they're limiting their social life, which is bad. Anything you'd like to add to that, Glenn?
All I'd say is that sometimes, you know, you can tailor, in terms of quality of life, tailoring the treatment to the individual, what's bothering them the most. And so that's where it's very important to not make assumptions, but really try to understand, you know, what's bothering them and then focus in that direction.
Right. And that kind of leads us to this whole shared care idea, doesn't it? The idea that we're discussing this with a patient and having them help us make a decision, or we're helping them make a decision on what to do. And one of my attendings once taught me that we have a debt to our patients: diagnose, educate, and treat. And this really falls in line. You have OAB. This is why you have it. This is what's going on. Let's talk about some various options for you, which we'll talk about in the next section, to make it fit for your lifestyle. That's great. So what we're going to do is we're going to shift in second, and we're going to talk about the OAB in the male patient. Thanks.